Thank you so much. Good afternoon. It's a pleasure for me to be here. Thank you for the invitation. My name is Galimany. I'm a former IPC fellow, and I'm very pleased to be presenting here this challenging case of a patient with infection. So it's about a 25-year-old male with history of plaque psoriasis since he was 17 years old. He had affected areas as you can see there, his scalp, face, trunk, folds, and genitals, and he had an initial PASI score of 12. Following this, their comorbidities, he suffered from depressive disorder, restricted eating disorder, allergic rhinitis. He also has had secondary syphilis that was treated with penicillin 6 months ago, and also perianal warts, HPV positive, treated with surgery more than 1 year ago. And he was taken at that time fexofenadine and fluticasone spray for his allergic rhinitis. So unfortunately, I don't have clinical photographs of the first consultation, but I can tell you that the PASI score was of 12. He was naive to systemics, conventional and biologics also. So we decided to start methotrexate 20 milligrams per week and folic acid 5 milligrams per week. He was doing fine. He was taking the regular labs without any alterations. So after 3 months, he had a PASI response of 75. He was pretty happy with this response, and we decided to continue the treatment. So we did that, and after 9 months, so in total 1 year from the initial consultation, he sent us an email telling that he had 5 days of abrupt onset left occipital headache that rapidly evolved to holocranial pain, very intense pain that was unresponsive to painkillers, associated with feverish feeling, photophobia, phonophobia, fatigue, nausea, and vomiting. So obviously, we texted him back and told him to go to the emergency room, emergency department of our hospital. And these were his vital signs when he arrived: without fever, but high blood pressure, heart rate was a bit high also, and severe pain. He was examined by the neurology team, and they didn't find any focal disabilities or sign of meningeal irritation. The general labs were all normal, and also COVID-19 testing was negative. So we performed a head and neck angio-CT scan, which also resulted normal. And finally, the neurology team decided to perform a lumbar puncture that resulted with a high protein count, normal glucose levels, high leukocytes, and a bit of erythrocytes also in the cerebrospinal fluid. So looking for an infectious cause, the PCR multiplex for bacterial and viral amplification resulted finally positive for varicella zoster virus. So this was a varicella zoster virus-induced meningitis. So the patient was admitted. We obviously decided to stop methotrexate at that point. He was started with intravenous acyclovir for 7 days and then switching to oral valacyclovir for another 7 days. So after 2 weeks, he was doing fine without any sequelae. So he was discharged, but 1 week after being discharged in his home, he sent us this photograph. So he was now presenting facial palsy associated with walk instability, retroauricular pain, and hyperacusia. So we told him to come back to the hospital, and new lumbar puncture was performed with high leukocytes, protein levels, and glucose levels were normal. And again, another rapid infectious panel was taken, this time with a PCR positive for human herpes virus 6 and negativity of herpes simplex virus 1 and 2 and varicella zoster. So we know that HHV6 could have false positive results, and we decided with the laboratory team to perform this exam in duplicate and triplicate, and the reanalysis resulted finally negative and also in peripheral blood. So this was interpreted finally as a Ramsay-Hunt syndrome without any vesicles in the skin, which is interesting, but he had the hearing problems and also the facial palsy after the diagnosis. So the management was again with intravenous acyclovir, but with bigger doses, 12.5 milligrams per kilogram every 8 hours for 14 days, with good clinical response, and the patient was finally discharged. So I wanted to review with you some interesting topics related with varicella zoster virus in relation to immunosuppression, especially in psoriasis patients, and its prevention. So we know that varicella zoster virus is a neurotropic human alpha-1 virus. In the initial presentation, this manifests as varicella, and during the recurrences, we can see shingles, or known as herpes zoster, but we can also have neurologic manifestations such as encephalitis, meningitis, Ramsay-Hunt syndrome, cerebralitis, myelitis, and also stroke. Some recognized risk factors for herpes zoster are older age, more than 50 years old, states of immunosuppression, infection, or mental stress. And one of the first questions that we asked ourselves was, which is the risk of herpes infection among psoriasis patients that are treated with methotrexate? And this is a very interesting article that was published in 2022, which is a retrospective cohort from Denmark. They used national registries, and they included adult patients with moderate to severe psoriasis that started either methotrexate or biologics. They gathered more than 7,000 patients, 2/3 with methotrexate, 1/3 with biologics. And here you can see the characteristics of the study participants. The mean age was between 45 and 50 years old, and the mean follow-up time was between 1 year and 2 years. So the interesting thing is to know the cumulative incidence of the alpha herpes virus infections. So we are considering here herpes simplex 1 or 2, and also varicella zoster. And the follow-up time, as you can see, is up to 2 years. So from the top to the bottom, you can see the red area that corresponds to TNF-alpha with the highest cumulative incidence. Then the green line corresponds to methotrexate. And then the lower lines are the yellow one that corresponds to IL-12/23 inhibitors, and the yellow one, which is IL-17 inhibitors. So methotrexate is under the incidence of TNF-alphas, but it's higher than IL-12 and 23, and also IL-17. And what happens with JAK inhibitors, small molecules that are being used more and more? This is a very recently published systematic review and meta-analysis from the Blue Journal. They searched for randomized controlled trials reporting infection outcomes in adult patients with moderate to severe psoriasis that were treated with JAK inhibitors. They gathered more than 13 studies with more than 6,000 patients. The mean age was 47, 46 years old. And here you can see the meta-analysis in which they have, different clinical studies. This is the incidence of herpes zoster. So the first group are the studies that considered tofacitinib, and they calculated the odds ratio of these patients, which resulted to be 3.77, and this was statistically significant. But on the other hand, if we compare the second group, which is deucravacitinib, the selective inhibition of TYK2, versus placebo, there were no significant differences. That's interesting also. So how can we prevent herpes zoster and its related complications? Probably the best answer is vaccination. There are two forms of the vaccine, which the first one is the live vaccine, which I understand that it's not available anymore in the US. It's a single dose, not recommended for immunocompromised patients. And the second one, the newer, it's the recombinant called Shingrix. This is a double dose administration, 2 to 6 months apart. It has higher efficacy with more than 90% efficacy in adults older than 50 years old. It's the only one approved for individuals older than 18 years old with low-grade immunocompromise. And I wanted to share with you also this systematic review that was published in 2019 from the Medical Board of the National Psoriasis Foundation. Just as a summary, I wanted to say that the recombinant vaccine is the preferred one, ideally before the initiation of systemics, but may also be given safely according to these recommendations with conventional systemics, biologics, and also targeted synthetic DMARDs. So the recommendation is to suggest it to all patients more than 50 years old and those that are under 50 years old, especially those who are using JAK inhibitors, systemic retinoids, or combination of systemics, for example, small molecules, or conventional, for example, with biologics, that will be the indication. So finally, what happened with our patient? Fortunately, he did not have any neurologic sequelae. We decided not to initiate immunosuppressive drugs, so we started on acitretin, 30 milligrams per day with partial response. So then we decided after 6 months to combine narrowband phototherapy. He wasn't tolerating very good the side effects of acitretin, so we down-dosed the dose of acitretin to 10 milligrams per day, and this was the final response. So he was very grateful, very happy. And this is the end of my presentation. Thank you for your attention.
Thank you so much. That was a really great talk. We're a little over time, but I'll say that I think, first of all, the talk was terrific, and I think as dermatologists, we sort of know when patients are headed towards more immunosuppression, who may need a JAK inhibitor, and so I'm often getting people ready for Shingrix, knowing where they're going, right? And so, but my question for you is, in your country, do you use the live chickenpox vaccine for children now?
Yeah.
Yeah, and so if someone's had that vaccine as a child, and now they're in their 20s, and they're going to go on a JAK inhibitor, do they need a zoster vaccine or no? Because I've heard no.
Yeah, I'm not sure about that answer, but yes, we have, well, the varicella vaccine, but we don't have the Shingrix in Chile. So that's really difficult for us, especially for patients more than 50 years old, which we know that the indication is very clear, but we haven't get it into that point in order to question if it will be necessary to vaccine also those patients with Shingrix. I'm not sure, and I haven't had pediatric patients also in that scenario, but yeah,
All right, good.
It's an interesting thing.
Keep them
I will keep it in
Thanks
mind.
so much.